Okay, let's go ahead and get started, everybody. First of all, welcome. Uh, Thank you for taking time out of your busy days to come here and lunch with us. And if you're in the room, and join us virtually if you're not. That we want to remind you that this presentation will be recorded, and we really take your feedback seriously. So please take the time to fill out the quick survey instruments, because we really try to do things that are of benefit to the whole department. So our topic today is a really interesting couple of topics, and it really highlights something that's unique about our department. And that is we have this fourth-year fellowship option, which allows fellows to craft a unique learning experience to gain expertise in a particular area of focus. So thank you to Logan Harper and Dr. Natalie Hamilton for being here today. And there are our two fourth-year fellows. So every year we sponsor two of our fellows to do this special fellowship. And we're honored to hear about your work. So they've done innovative work in disability medicine and climate health, which I think our institution is really at the cutting edge around climate medicine and climate health, which is way cool. And disability, which has been around a long time, but how do we begin to think about it in a way that where can family medicine contribute to the needs as that population gets older? So Dr. Logan Harper, Junior Faculty Fellow in the Department of Family Medicine, as well as a recent graduate of our Climate and Health Policy Fellowship. Over the last year, he's collaborated with the CDC to advance their heat and health initiative, and is now working with the University of Colorado, Healthy Air and Water Colorado, and the City of Denver to promote heat resilience at a local and regional level. Heat was a big issue. I'm from Arizona, so heat was a growing and continues to grow issue there. In October, he will begin a new role as Assistant Fellowship Director in the Climate and Health Program and Assistant Professor in the Department of Family Medicine. So we welcome you, Logan. Dr. Natalie Hamilton, Senior Instructor of Family Medicine at the University of Colorado. She completed her residency training at University of Colorado, our residency, and joined the team as a faculty fellow in 2024. She's also a graduate of the Leadership Education in Neurodevelopmental Disabilities program, which really focuses on intellectual neurologic disabilities, primarily focused in peds. And her background includes being a direct support professional for Special Olympic athletes, participating in population health projects for improving healthcare disparities for patients with disabilities, and enhancing medical education around disability care. So please join me in welcoming, looks like you're up first, Natalie.
Hi, everyone. Can you hear me okay? Perfect. For those of you I haven't met, I'm Natalie Hamilton. And again, I wanted to thank the department for this fellowship and for having Logan and I speak today. I think after today, you'll really see how we've been able to structure this fellowship to further our interests in our future careers. I have no financial disclosures to report. And I first wanted to start by telling you a little bit about what my fellowship looked like. Like Myra mentioned, I was a LEND fellow, and this is an interdisciplinary training to enhance clinical experience and leadership skills in caring for patients with neurodevelopmental disabilities, including autism. The interdisciplinary part is really unique to this. There was about 20 of us in the group, ranging from physical therapy, occupational therapy, public health, genetics, just to name a few. And then the really great part is they have parent advocates and self-advocates to give that lived experience in the program, which was really valuable. There are 60 LEND programs located in 44 US states across the country, and we have a location right here at Children's Hospital of Colorado through JFK Partners. And it was started in the 1960s by the JFK Foundation. Some of you might not have known that JFK had a sister, Rosemary, who had an intellectual disability. And his other sister, Eunice, was a huge disability rights support advocate. Unfortunately, their funding was cut by the current administration, but they're looking for other funding sources and are hoping to have a small class this year. Some of the other fellowship opportunities that I participated in was I was sort of a mini developmental pediatrics fellow, was able to join them in their clinics and in their didactic sessions and participate in autism evaluations. I joined some opportunities with physical medicine and rehab, where next week I'll be doing some Paralympic physicals down in Colorado Springs. And then a huge component of my fellowship, one that I've really valued, is being part of the Justice League and now the Departmental Engagement Program. Some of our team is here today supporting, and they're just an absolutely amazing team, and I've learned so much from them. And so I've been able to give the disability and accessibility perspective for our programs in the department. And then resident curriculum teaching for our family medicine residents. With Alicia Wong, we are excited that we got an inclusive health grant through Special Olympics, so we'll be able to expand that teaching next year. And then last but not least, policy and advocacy. I was able to go to Washington, D.C. twice, once with LEND and the other with an SDFM scholarship through AAFP to do the Family Medicine Advocacy Summit and advocate for protecting Medicaid. These are just a few pictures from my fellowship year in Washington, D.C., and then with my mentor, Laura Pickler, who was instrumental in helping me to develop this fellowship. And then in the bottom right corner, you might notice a few familiar faces down there too. So the learning objectives for today, I'm hoping you'll understand the scholarly project that I did, which was looking at comfortability of family medicine providers regarding genetic testing and why genetic testing is important in patients with autism and intellectual disabilities. To review a case example of something that providers may see not uncommonly in clinic and how that impacts their care. Discuss strategies for integrating genetic testing in clinical practice, and then recognize the importance of interdisciplinary collaboration. I would like to acknowledge that genetic testing in individuals with autism and intellectual disabilities is complex, and people have various perspectives on it. And I acknowledge there are several factors involved in this decision: ethical considerations, psychological impact, and implications of uncertain results. But my aim is to ensure that patients and families are fully informed and supported throughout the process, that we're always respecting their autonomy, and that it's ultimately their choice if they decide to get genetic testing. So my scholarly project this year, I wanted to focus on enhancing access to genetic testing for individuals with autism and IDD by providing education to clinicians in the primary care setting. Just a little background on autism. So the prevalence of autism for children is currently 1 in 36 in the US, and in adults 1 in 45. And you may have heard things about why this prevalence is becoming more common, and we think it's because of the diagnostic criteria and the better access to availability and testing for autism. The DSM-5 diagnostic criteria for autism is 2 domains. You have to have both social communication difficulties and repetitive and restrictive behaviors. And the average age of autism diagnosis is 5 years old in the US. And then for intellectual and developmental disabilities, this is a condition characterized by limitations in intellectual functioning and adaptive behavior and needs to originate before the age of 22. The intellectual functioning can be measured by an IQ test of a score of less than 70. But in Colorado, they also recognize adaptive skills. So you may see things like the Vineland score, where they look at patients' everyday activities and how they're able to adapt those skills in their environment. So the background for this project: genetic testing can help in diagnosing autism and intellectual disability, with genetic causes identified in 10 to 40% of cases. When a patient has both autism and intellectual disability, this is much higher. We find a much higher genetic cause. And the American College of Medical Genetics and Genomics does recommend that all individuals diagnosed with autism and IDD be offered genetic testing. This was one of the first recommendations that they gave. And I believe that primary care providers are uniquely equipped to provide counseling on genetic testing for this population. And what we see is implementation of genetic testing in this population remains still very low. So I created a survey at a single site family medicine clinic at AF Williams and gathered data on the challenges faced by family medicine providers regarding genetic testing for patients with autism and IDD. It had both quantitative and qualitative questions, and we performed some analysis to identify common themes and understand the likeliness and comfortability of family medicine providers. So these were the results that we found. We found that 60% of family medicine providers estimated that they had 1 to 5 patients with autism or IDD. 30% thought they had about 5 to 10, and a small percentage of providers seem to be seeing most of the patients in clinic with autism or IDD. Of those patients, providers thought over half had never received genetic testing, and a little over 40% thought maybe 1 to 5 had received genetic testing. We then looked at the likeliness to order or refer for genetic testing in children on the left versus adults on the right. And overall, we saw a very low likelihood to order genetic testing, a little more likely to refer for a child with autism or IDD, but still overall unlikely. And then this graph shows the comfortability of family medicine providers in regards to genetic testing. So for ordering genetic testing, counseling on a positive result, and counseling on a variant of unknown significance, overall close to very uncomfortable. Counseling on a negative result was closer to neutral, and then the total comfort score was uncomfortable. So the conclusions that we found was there's a large gap in the number of patients per provider compared to the prevalence rate that we know of for people with autism, and more than half have not received genetic testing. It's unclear where these patients are going, if they're staying in special care longer than they need to be, which we know is happening, or if they're going to other specialties. And family medicine providers were found to be more likely to order or refer for genetic testing in a child versus an adult. And this wasn't shown on the graph, but much more likely to order genetic testing if there were additional dysmorphic features. So physical exam features that made them think there was a genetic condition going on. Like I said, the total comfort score was overall low in family medicine providers. And there was a correlation seen between providers who think it's important for patients with autism and IDD to receive genetic testing that made them more likely to refer for genetic testing, especially for a child. So future directions from this project were, with the growing prevalence of autism, there will be an increased demand for genetic testing in this population. And I think family medicine providers can help to meet that demand. I've talked to multiple geneticists and genetic counselors in our department and outside of our department, and they say, we can't see every patient with autism and IDD. There's not enough of them. And so how do we bridge that gap? And increasing knowledge and education about the importance of genetic testing could increase the likelihood of family medicine providers to refer or order. So I just wanted to look at genetics then and now. Before, we knew genetic testing was very costly. It was rarely covered by insurance, and it was mostly used in academic settings. But now with technological advancement, these testing costs have rapidly decreased. We have enhanced efficacy and expanded access. Most payers are covering testing because of the number of clinical indications and the utility and patient demand. And genetic testing should be accessible and offered regardless of location or socioeconomic status. Quickly, just looking at the types of genetic testing, I won't go into a lot of detail here, but the first line was still recommended to be the chromosomal microarray, looking at the copy number variations, and then short tandem repeat testing is where we look at those repeats like for Fragile X. But more commonly now, we're seeing targeted gene panels, and there are gene panels available for autism and IDD. And then more so now, we're also seeing an increase in whole exome sequencing and whole genome sequencing to get more information. So a lot of things to look forward to in the future for genetic testing: improved rates of diagnosis, increased coverage and lower costs, a lot more trials for gene and cell-based therapies, and an interesting way to look at models of care for delivery for genetic conditions. So I wanted to go through this case example that someone you might see in your clinic. This is a 4-year-old boy named Alex. Alex's parents have noticed that he has been experiencing developmental delays, particularly in speech and language. He's exhibited behaviors such as hand flapping, difficulty maintaining eye contact, and challenges with social interactions, which has raised concerns for autism. Some more history: he's had his first words at about 3. He showed repetitive behaviors such as lining up cars. He had sensory sensitivities, such as difficulty with loud noises and certain textures of food, and didn't really seem interested in kids his age. Family history: Alex's maternal uncle had intellectual disabilities, but no formal diagnosis was known. And then on exam, you see some low tone, long face, prominent ears. So you order genetic testing, and the results are positive for Fragile X. And I think Fragile X is a really good example, especially for family medicine. This is caused by a mutation in the FMR1 gene. It has implications for family planning, and I'll talk about that a little bit more. There are targeted interventions, no cure, but there are services tailored to Fragile X. And at Children's Hospital, Nicole Tartalagia is a leading expert in Fragile X and has been doing some really cool work over there for interventions. And then this component, research and resources, is what I hear the most from families. Just having a reason, something that they can name for why they're seeing the difficulties they are. It alleviates a lot of guilt, and it allows them to find community and other patients like themselves that they can connect with, and that is priceless to them. And with the impact on family members, you might be seeing this patient's mom and their grandfather in clinic. And so the mom, if she had the premutation for FMR1, it could impact her because she'd be at risk for primary ovarian insufficiency. And so you may counsel her differently on fertility planning and when to have more kids if she desired. It also increases her risk for other health issues, such as osteoporosis. And so this may lead to proactive management and more preventative care on your part. And then for the grandfather, if he had the premutation, let's say he comes into your clinic and all of a sudden he has a new tremor, maybe a little bit of an ataxic gait, and he's having cognitive difficulties. And if he had the premutation, he would be at risk for Fragile X associated tremor and ataxia syndrome. And this looks similar to Alzheimer's. And so knowing this could change management and care strategies for him. So to summarize the impact of genetic diagnosis: it helps us make informed decisions. It helps with management and surveillance. There's treatment and disease-modifying therapies. It helps align the care team. For example, if you had a genetic condition found that all of a sudden you now know they might have increased risk of eye problems or heart problems, you may get those specialists on the care team sooner and have more of a preventative care model. And then again, that advocacy and support, just highlighting that. The principles of genetic counseling: just wanted to highlight that these are things we practice every day: autonomy, beneficence, non-maleficence, and justice. But I wanted to focus on the informed consent piece because I hear that this is an aspect that is daunting for providers. And so for counseling patients on genetic testing, I have included some key components. The heme department on campus worked with the cancer center, and they helped to develop an informed consent that providers felt comfortable talking to their patients about, and that was tailored toward like leukemias and different heme-related conditions. So I'm hoping to have something similar in EPIC for autism and IDD, like a smart phrase with a script that providers can pull up and feel like they are not missing any of the key components. But some of those components that you would talk about would be what a positive result would mean, that a negative result does not rule out a genetic condition, what a variant of unknown significance is, that patients can opt into secondary genes so they can decide to look for hereditary cancers and cardiomyopathies, that we may find things we weren't expecting, and that there are risks and what those risk versus benefits are. So that mental health piece, life insurance, things like that, that you may see that there's different paternity or that someone is married close to the family tree. And then the GINA limitations, knowing that GINA does not apply to active military or businesses with 15 or less employees. And I also wanted to make it relevant to our institution. I spoke with a genetic counselor at the Hereditary Cancer Center. She's been there for 25 years, and she was able to give me some insight into what UC Health is doing with genetic testing. And she said most departments who are doing genetic testing are not using institutional billing because when they do, they have no idea what the patient will be charged. So instead, they're directly billing the patient's insurance and working with the genetic labs, such as Invitae or GeneDx. And with this model, they can keep out-of-pocket costs down. So one of the genetic labs will start the prior authorization, for example. They'll call the patient if they owe more than $100 and give them the option for self-pay, which is usually about $250. Invitae has a cost estimator, so you know what the patient will owe, and they also offer a lot of financial assistance programs. And then Medicaid and Medicare are largely covered if the patient has a clinical indication, which they would for autism and IDD. So another thing that I hear a lot from providers is, I don't know how much it'll cost the patient, it's too expensive. But what we're seeing with this model is they're at max paying a couple $100s. And then positive result, you'll have a lot to talk about, but I think this is where we can triage a little bit better and then have the geneticists and genetic counselors talk to the patient about what that means. No result is really going to be urgent. I know that'll be hard for the patient, but making partnerships with geneticists, I know our wait time is really long here, but there are private practices in the community that can also do this. And then if receiving a negative result, just to highlight, it cannot rule out a genetic condition. And if you have a high pretest probability, this is where if you do the panel testing and you still think this seems genetic, if you move to a whole exome or whole genome, about 20% get a diagnosis from those. And then variant of unknown significance, I just wanted to highlight that the literature shows more than 90% of these are reclassified as benign. It's just we need more population data to be able to determine that. I have genetic resources on here that are available for providers if you're interested. And then just wanted to send a special thanks to Lend and JFK Partners, to Patrick Long, who is the geneticist that I worked with at Sequence MD to help with this presentation. And then my mentors, Alicia Wong, Laura Pickler, and Cleveland Piggott, and Linda Montgomery in the department for having us and for allowing us to do this fellowship. Thank you. All right, Logan, you're up.
All right, thanks for having me. I have more than 30 slides in less than 30 minutes, so I'm going to jump right into it. But throughout my time in my climate and health policy fellowship, I would say, I was working with the CDC on their heat and health initiative, which was focused on how do we get patients and providers to understand heat risk and protect themselves from it. And then I was working with the city of Denver on community heat education seminars, and also doing advocacy work focused on politicians. And the main through line from all of that was, how do we communicate about climate change and its health risks as healthcare providers? And it's surprisingly daunting, right? There's a lot of challenges that I'll get into, but I wanted to take the key points that I learned this year and share them with you all. Yeah, okay. So my learning objectives here are just to understand what the challenges and opportunities are. Also understand that you probably already have the skill set to talk about this stuff. We'll give you some case examples to kind of highlight that, focused on tobacco misinformation, how it compares to fossil fuel related climate misinformation, and then also talking about vaccines. And then we'll reinforce some key principles of science communication, how it applies to this field, and then discuss some touch points for practically during a clinic visit, clinical environment, how can we incorporate this stuff? So starting off with why aren't we talking about it? I think there's two key buckets here. And the first one is that we're worried about the public perception of climate change. We want to make sure that we're building trust with our patients, and we don't want to bring in politically divisive topics that might erode that trust. Also, a lot of folks don't really understand the connection between climate and health. And so if we're confronting patients with something that they really have no baseline understanding of, that in and of itself is kind of a daunting prospect. On top of that, both probably us and our patients can take a head in the sand mentality when it comes to climate change because it's just a depressing thing to face up to sometimes. And it just feels easier not to talk about it. But ultimately, that makes us feel more isolated and worsens anxiety rather than giving people tools to cope with the actual issue. And I already mentioned the worries about politicization. The other bucket is just issues related to bandwidth and systemic barriers, right? We don't necessarily have the time or the institutional support or the financial incentives to talk about this stuff in our very limited clinical time. And a lot of folks also lack the knowledge and confidence in the impact of bringing up this discussion in the first place. So moving on, we'll talk about a couple of case studies here. This might seem like a pretty long tangent, but I want you to understand what you're up against in terms of the milieu of disinformation around climate and health and why it's so important that we step up and fill the void when it comes to accurate information. So just looking back at what tobacco companies have done over the last 70 years, in the 1950s, it was abundantly clear that there was a connection between lung cancer and smoking, but the tobacco industry started a comprehensive disinformation campaign where they were intentionally spreading false information to question that scientific consensus. In fact, I wanted to quote this 1950s newspaper ad that read, "For more than 300 years, tobacco has given solace, relaxation, and enjoyment to mankind. At one time or another during these years, critics have held it responsible for practically every disease of the human body, and one by one, these charges have been abandoned for lack of evidence." This disinformation campaign continued up until the modern day. In the 90s, Philip Morris created basically, they hired a PR firm to create a pseudoscientific organization to publish information questioning the scientific consensus, successfully delaying and derailing regulation of tobacco. And we're still seeing it today with Juul, flavored tobacco products, et cetera. Physicians initially were pretty content to sit back and get money from the industry for talking about how Camels are doctor's number one choice. And, if you have filters, your cigarettes are much more healthy. But by the 1970s, that tone had shifted significantly, and you had the AMA publicly calling out tobacco companies for duping the public. Those advocacy efforts made a huge difference in getting substantial regulations through Congress. Spoiler alert, fossil fuel companies are doing the exact same thing, right? They're literally using the same playbook over the same timeline and oftentimes hiring the same people to enact the playbook. So the similarities are obvious, but from the 1950s on, the science around the greenhouse gas effect has been abundantly clear. And in the 70s, Exxon published a bunch of internal documents acknowledging that, but they suppressed that information and embarked on another comprehensive disinformation campaign meant to derail regulation of their own industry. And so one of those examples is an open letter that another kind of pseudoscientific but legit sounding organization published in 1998 that says, quote, "We are living in an increasingly lush environment of plants and animals as a result of the carbon dioxide increase. Our children will enjoy an earth with far more plant and animal life than that with which we are now blessed. This is a wonderful and unexpected gift from the Industrial Revolution." So very rosy picture, even though we're now 20 years past when we know the Exxon Corporation itself knew about the devastating impending environmental impacts. On top of that, the fossil fuel industry literally published a fake PNAS paper where they use the same formatting, the same font, and circulated a fake scientific article questioning the scientific consensus around climate change in order to erode support for the Kyoto Protocol, which was the major international climate agreement of the 1990s. And then I just wanted to highlight this guy who worked for the same Philip Morris PR campaign and now runs a website called junkscience.com, where he promulgates all this fake news about how air quality doesn't hurt people, which we know is not true. I'm going to skip this slide, but Exxon spending millions on disinformation. It's hard to keep doing this, right? Because even if you're not very scientifically literate, at this point, you really just have to look outside and see how hot it is or how smoky it is or whatever to understand that the climate is changing. And so we've seen the fossil fuel companies pivot to a greenwashing model with things like offering carbon neutral driving, which is absurd. Chevron bills itself as leading the way in the energy transition, even though they spend about 0.2% of their capital expenditures on low carbon energy. And there was a study on this in 2022 where they looked at the oil production from the 5 biggest oil and gas companies compared to the rhetoric around climate and health. And so this green line are climate keywords like sustainability, transition, green, clean. We see 120% increase in the use of those words in company reports, all while there's no change whatsoever in oil production. And just to put this in perspective with other harmful industries, this line right here, well, the tall one on the left is spending by the tobacco industry. And you can see that precipitous decline in the late 90s. That's a direct result of federal regulation on where they're allowed to spend money, right? At this point, these lines represent alcohol, gambling, tobacco, and ultra-processed foods. Oil and gas spends $113 million on lobbying in the US, which is more than all of those other industries combined. So this is successfully derailing our energy transition, and it's also causing direct, local, tangible health impacts because the burning of fossil fuels is the primary driver of air pollution, which is in fact the second leading cause of premature death globally. It kills about 5 to 8 million people a year, depending on how you count. So what this amounts to is a misinfodemic. We've heard this term a lot throughout COVID because as primary care doctors, we're in the trenches trying to convince people to get vaccinated. And we already recognize from that experience that it's our job to stand up and fight the infection of misinformation. So the Surgeon General actually published a report on how to do that. And it starts off with understanding why people share this misinformation, right? So when Shell and Exxon are doing it, it's nefarious and intentional, and we call that disinformation. But when your crazy uncle's doing it, it's because probably he wants to feel like he's providing information to people he cares about. He wants to protect those people. He wants to seek explanations for things he doesn't understand, and he might want to feel connected to others who are already part of that community. And so these are really understandable motivations that we can empathize with. How do we address it, though? It starts with listening and empathy. So those are obviously core skill sets for family doctors, but we would need to make people feel like they're not being othered or victimized. We need to validate their experience and use phrases like, there's a lot of conflicting information out there about climate change. It's really hard to know what to trust. And when you can validate somebody's perspective like that, they're much more likely to hear what else you have to say. And once you've built that trust, you move on to pointing out credible sources and emphasizing that they don't receive any sort of financial benefit from providing high quality information about climate and health. You don't publicly shame people. And of course, you want to use inclusive language that makes it clear that they're not being impacted by the health impacts of climate change. We all are, and that we're all in this together. When we do this kind of communication with vaccines, it makes a huge difference in patients' willingness to consider getting a COVID vaccine. So this study came out shortly after the start of the vaccine became available, but it tested different messaging techniques for primary care doctors to get folks who are either vaccine hesitant, saying they're initially not sure if they're going to get it on the left, or no, absolutely, I won't get the shot on the right. And the first message, M1, says, what do you think about getting it? And obviously that was pretty ineffective. across the board. But when we give people a hard and fast recommendation, followed by just a little bit of evidence that supports it, it makes a significant improvement for almost every message, no matter which one you pick, for the not sure crowd. And then for the initial no crowd, when you focus on an argument centered around protecting others, that almost doubles the percentage of folks who are willing to consider getting a shot after receiving the message. And that's obviously very applicable to climate change, right? So now I want to just move on to some more practical tips around how we talk with patients about climate change. And if we have time, we can touch on how to discuss with the public. One of the key take-home points I want you to all take from this talk is that you, as a family doctor, are one of the most trusted, if not the most trusted source on climate and health information in this country. And that might feel a little bit overwhelming because you may not feel qualified to be a trusted source on this information, but most of it is really not that complicated, right? Heat is dangerous, smoke is dangerous. There's a lot that we can do to stay safe and to reduce the likelihood of it getting worse in the future. Messages like that go a long ways. This is some polling from fall 2024 on the right, and it just shows that all the data points on the right side of the chart are the most updated numbers. The left side are from 10 years ago. So you can see that primary care doctors and first responders, 60% of the public trust us on climate and health, and that's 10 points better than it was 10 years ago. We're 10 points ahead of climate scientists, and they're ahead of everybody else. When we break it down by political affiliation, also, I just have to flag that this is a very political talk. You can't talk about climate change without talking about politics, so bear with me. When you look at conservative Republicans, primary care doctors are the second most trusted source of information on climate change after family and friends, well above Fox News. So the people who perhaps need to hear the message the most are most likely to respond to it if it comes from you. I want to move on to a case. So we're going to call this guy Jim. He's a patient of mine I've had on my panel for about 4 years. He's 78. He's got chronic or congestive heart failure and a whole bunch of other comorbidities, takes a lot of medicines, all of which, both the conditions and the meds, increase his risk of heat-related illness. And he showed up to clinic about a month ago wearing this exact hat. And I was like, you've been hospitalized several times within the last year for heart failure. I should counsel you on heat-related risks so that we can try to eliminate the risk of that happening over the coming hot months. I started off by saying, Jim, I feel like I need to talk to you about heat because summers are getting worse, and we know that for folks like you, that can really put you at risk of ending up in the hospital. And his first response was, yeah, so much for those climate change people, huh? And I was like, I just paused for a second and I was like, Jim, the message I want you to hear is that I think you're at risk because summers are so hot, and I want to just make sure you know how to keep yourself safe. And he thought about it for a second, and then he was like, oh, I must have gotten that backwards. And I could just see his defenses melt away. And on talking to him further, I realized he doesn't have air conditioning. He doesn't have anybody in his life to check in on him. He didn't realize that heat was a health risk factor, and he didn't know how to recognize symptoms of heat-related illness. So he's like the highest risk possible person, and it would have been really easy to avoid having the conversation because of the hat. But I didn't use the words climate change, but I think I still made a positive impact on him because we sat down and filled out this is a heart disease focused heat action plan, which is a resource on the CDC website. And it's just a one pager that gives patients some tips on, how to stay safe during a heat wave, including how to recognize heat-related illness symptoms, how to adjust their meds, when to call their doctor, how to understand heat risk. So that QR code actually brings you to a website that tells you what the heat risk is in your neighbor or in your zip code today and for the next week. I'm not going to read through all these, but I want to just hit home 7 key principles about talking to patients about climate change. We'll go through them one by one. The first is don't worry so much about politicization, right? We are super trusted on this, and conservatives respond well when we talk to them about it. You can tailor your message so that you're not overly provocative, right? We're used to seeing charts like this where the blue line representing progressive shows people really worried about climate change, wanting their leaders to take action on it. The red line shows people who are conservative, not caring so much about it. But it's actually much less politicized than you'd think when it comes to specific climate policies. So on the left, we've got polling of Republicans on the left, Democrats on the right, about specific climate-related policies that also impact health. So planting a trillion trees to absorb carbon emissions, 87% of Republicans support that. And by the way, that makes a huge difference on urban heat islands. It cleans up air quality in polluted neighborhoods. So it has a major health impact too. Requiring oil and gas wells or companies to plug gas leaks, methane gas leaks from oil wells. 77% of Republicans support that. Methane from those leaky oil wells in the Front Range is a huge contributor to the ozone pollution that we have here, which, by the way, we're the 6th worst metro area in the whole country for ozone pollution. And it is projected to kill about 800 Coloradans every summer. So plugging methane gas wells is a huge way for us to improve our community's health while also fighting climate change, and pretty much everybody supports it. When we look on the right at just different forms of, sources of energy and who supports them, Republicans support all forms of energy. This narrative that wind and solar are politically unpopular on the right is not true. It's a narrative voiced by national political leadership, but the everyday Republicans that you might poll about solar panels, they want more of them because they've seen huge benefits in their communities because renewable energy is disproportionately sourced in the reddest areas of our country. The second point is simple, clear messages repeated often by trusted and caring messengers has the biggest impact. We don't need to get too complicated, but we need to deliver a clear message, and we need to start with why we care. So this is a 2017 study. Just ignore the bars on the left where it says control. We're just going to talk about the treatment here for a second for the sake of time. Red bar is conservatives, blue bar is liberals. The pre-exposure chart is on the left, so you can see, and what we're measuring is on the y-axis is what percentage of folks accept the scientific consensus that human-caused climate change is real, right? About 60% of conservatives and 80% of liberals do prior to getting any messaging around it. You give them a simple message from a caring healthcare provider who they trust that says at least 97% of climate scientists have concluded that human-caused global warming is happening, and you see a 20% jump amongst conservatives, 10% jump amongst liberals, and decreased polarization in terms of the difference in their acceptance of that fact. I'm going to skip this for time too. So meeting them where they're at is the third principle. These are just the key components of motivational interviewing. We do it all the time if we're talking about diets, exercise, smoking. We don't want to argue with people. We want to make sure that they feel empathy from us so that builds trust and they, are willing to go along with our suggestions. We want to point out discrepancies, which means if they are doing something that is not in line with their goals, we want them to understand that and then come to a realization around what sort of behaviors would be in line with their goals. And that might be improving your cardiovascular health, focusing on eating plant-based diets, active transportation, riding your bike to work, those sorts of things are climate action, but they're also aligning people's actions with their health goals. And then I think the last point here, support self-efficacy, is the most important one for climate and health, because climate change is a problem that makes people feel isolated and hopeless. And a lot of folks who know about the problem and are really worried about it feel totally helpless and isolated, and they don't have a community to support them in this. And part of that is because of the head in the sand mentality. And part of that is because of the messaging that we've all received for decades around personal carbon footprints and feeling like you have to, stop flying for vacation in order to fight climate change, when in fact, this is a, systems level problem that requires like international cooperation to fix. So I will not hesitate to talk to patients around, the importance of collective action here, because it both benefits their mental health, it reduces rates of climate anxiety, and it makes them more effective. So if you can do something that feels impactful around climate change, studies show it makes your mental health related to the issue quite a bit better. Examples of organizations people could join that are not health related would be Protect Our Winters, Citizens Climate Lobby, 350, Indivisible. There's like a million different advocacy organizations that just are desperate for folks to sign on. And they'll give you things to do, ways to show up and build community, ways to show up and have your voice heard in a politically impactful way. So it can go a long ways towards feeling self-efficacy. Identifying clinical touch points. There's a lot of ways you can bring this into your clinical practice, right? One is just healthcare screenings. So everybody in the front range should know how to check air quality and respond appropriately to bad air quality days. Everybody probably throughout the country should know how to check heat risk. We're seeing areas like the Pacific Northwest that traditionally not hot. People don't have air conditioning. It was 116 degrees in Portland 3 years ago. Taking an HPI, if you have a patient who has an exacerbated condition, why is their asthma worse? Why can't we dial in their diuretic dose? Maybe it has to do with air quality or heat exposure. Be screening for that when you're thinking about exacerbation of these chronic diseases that are impacted by climate risk. Chronic disease management, I already kind of focused on that with Jim, so I'm not going to harp on that too much. Discharge planning presents potentially a time where you have a little bit more time and bandwidth to discuss with folks. And then the fifth point is just trying to create prompts in your clinical environment for civic engagement. That can be a QR code on your badge that helps people register to vote, as simple as that. Or it can be a link to more resources for them to educate themselves. Lots of examples. The fifth point, focusing on personalized solutions, right? This goes along with motivational interviewing. We want to identify people's health goals and help them achieve those. Some four things I really want to hit home here are that plant-based diets and active transportation, there's ample evidence for both of them to support improved mortality outcomes, better cardiovascular health. This is a 2025 meta-analysis of plant-based diets. The y-axis is relative risk of all-cause mortality. The x-axis is adherence to the plant-based diet index. That's a very robust correlation. And there are many, many other studies that look exactly like this. Then we can talk about improving air quality both in the indoor and outdoor setting. That's sort of a separate lecture, so I'm not going to dive into it, but things like using fans, filters, using your HVAC, using the vent over your stove, especially if it's a gas stove, those can make a huge difference to improve indoor air quality, which is really important when outdoor air quality is bad, because you need a place to recuperate. And then disaster preparedness is huge, right? Unless you live in the central Denver metro area, you live in a place with much elevated wildfire risk. And we saw that with the Marshall Fire a few years ago. 1,000 homes burned down between, Boulder and Denver. And those are places that, people probably were living there not expecting to be impacted by wildfire, and so they probably weren't prepared. And so disaster preparedness is both a personal thing and a systems level thing. And it's something our clinics should be thinking about too, in terms of how do we support patients if they suddenly lose their housing or, are breathing in toxic air, et cetera. Sixth point, use existing tools. We do not need to reinvent the wheel here. The CDC has a ton of resources on this for both patients and providers, handouts that you can just give to people. Harvard and AmeriCares, that's the resource on the right, they co-published a guide for climate resilient health clinics, and they have it's super comprehensive, very user-friendly, and it's focused on patients, providers, and healthcare administrators. So if you're trying to build a climate-resilient health clinic or health system, there's a guide for that. And then I also wanted to highlight the importance of pamphlets. So these pamphlets are from an organization called My Green Doctor, and they will, they can contract with your clinic to make it more climate resilient, but they recently published a study looking at ways of communicating around climate risk. And it turns out patients' preferred way of getting information is through a pamphlet in the waiting room. So and it promotes positive behavioral adaptation. So you don't have to take any extra time. You literally just put these up, let people read them who are interested, and you're having a positive impact just by doing that. Seventh and last point is to prioritize systems level solutions. We can only do so much to increase how much we talk about this in our offices because we already are struggling to meet all the requirements of a 20-minute visit. So ways we can do that, the waiting room information's key, EHR automation. If Epic could tell us when a patient's at high risk of heat illness and some key, counseling that they need to have, that would make it really offload our burden. Employing non-clinician staff. So a lot of this does not have to come from a doctor or another healthcare, a clinician. It could come from a nurse, a case manager, a social worker, calling people, screening them for risk factors and giving them some basic pointers on how to limit their climate-related health risk. And then of course, we got to get paid for the extra time and work that this requires. I'm going to skip over this except to say that I just really want to highlight when we're talking about climate change in a public setting, studies show that identifying an opponent dramatically increases the efficacy of your message, and it also improves trust in the messenger, and that's across the political spectrum. So we see people on the other side doing this all the time, climate scientists or frauds funded by China, whatever. If you talk about the opponents for positive climate action being fossil fuel executives, their lobbyists, and the politicians in their pockets, that is a verbatim, tested, studied phrase that improves the efficacy of your message. So don't be afraid to call out who's obstructing progress here. Take-home points, we've done this with tobacco and vaccines. We can do it with climate change. You already have the skills. It doesn't take much. Brief, simple education has a positive impact, but keep it person-centered, positive, avoid doom and gloom, and solutions-oriented. Thanks.
Thank you so much to Logan and to Natalie for presenting today. We have about 5 minutes for questions. We'll take them in the room first, and I'll circulate with a mic, and then we'll take them online.
Well, thank you both for a very clear and very compelling pair of presentations worth coming to work for today. And I see why Dr. Montgomery kept telling us, you got to come, you got to come. That was terrific. I have a personal question for both, same question for both of you. Now that you know what you know, what are you personally planning on doing to advance your agenda? And what do you want to see the Department of Family Medicine at the University of Colorado do?
I love that question. So I am going to be working at the Lone Tree Primary Care Clinic in the department. And what my ultimate goal is I'm very passionate about transitions of care and transfer of cares into the adult world. I think that is a huge component that the department can bridge that gap. And so what I would love to see is a clinic that is focused towards people with disabilities, where we can have more time to help with those complex conditions and all of the transitions that warrants. And with my specific project, it would be looking at a clinic that could possibly pilot genetic testing. I know, like at AF Williams, we do prenatal screening and carrier screening, and I am not sure if that is institutionally billed or directly billed, but we do it in other things. So if it is an autism panel or IDD panel, can we pilot that somewhere like a clinic like that where we have time to counsel and talk about genetic testing? And I would love to see that happen in the department as well.
Yeah, thanks for the question. I think what I'm going to be doing differently is much more focused on systems level change, because trying to, prescribe more dry powder inhalers instead of MDIs, ways to improve the climate resilience of each individual patient is kind of akin to trying to ride your bike to save the world. I think that it's important that we all do it, but if I'm just working on me changing my clinical practice, it's going to have very limited impact. So right now I'm working on community education around heat illness and trying to collaborate with the residency, the city of Denver, and the advocacy organization that I work with called Healthy Air and Water Colorado to teach vulnerable community members how to stay safe. And then I think for the Department of Family Medicine, we need to give these tools to every clinician. And we also need to build out structures within our clinical workflow to, offload some of the work from them. So like I was talking about, having social workers or case managers identify high-risk people and provide them simple, clear education that can go a long ways. Oh, and one other thing is healthcare is like a massive, massive source of greenhouse gas emissions in this country. Our healthcare system is equivalent to the entire emissions of the UK every year. And so we can be thinking about, as a family medicine department, how do we reduce our emissions? And part of that is just by doing good primary care, right? Because keeping people out of the hospital is a major climate action. So, yeah.
Any additional questions in the room? Do I have any online?
We have no questions, but we do have some comments saying well done. And our graduate fellows are so impressive and inspiring. Amazing work, both of you.
Thank you.
Great. If there's nothing else in room or online, thank you everybody for coming. Please feel free to fill out our surveys, hint, hint, wink, wink. And thanks for coming.